Welcome to our Rheumatology series. This video is on systemic sclerosis. Systemic sclerosis is an autoimmune disease that involves multiple organs. Epidemiology. Systemic sclerosis affects women 3 times more frequently than men. Its prevalence ranges from 3.1 to 20.8 per 100,000 people, and it may occur at all ages. However, the peak incidence lies between the 4th to 6th decade. Its etiology is unknown. Pathogenesis. A hypothesis postulates that a vascular disorder of small blood vessels and connective tissue leads to fibrosis. Consequences believed to be associated with this are increased vascular permeability, endothelial apoptosis, platelet aggregation, and increased matrix production due to fibroblast-derived tissue growth factor beta and reduced matrix degradation. Signs and symptoms may affect the skin as cutaneous fibrosis or telangiectasia, the musculoskeletal system as periarticular tendon entrapment, periarticular nerve entrapment, flexion contractures, acral osteolysis, and myopathy, or the gastrointestinal system as esophageal dysmotility or malabsorption. The cardiopulmonary system can be affected as pulmonary hypertension or cardiomyopathy. The kidneys are affected in 60 to 70% of cases and include chronic and slowly progressive renal failure, which may present with proteinuria, hypertension, and azotemia. The kidneys can also be affected with acute and rapidly progressive renal failure, which often occurs as scleroderma renal crisis, with a clinical presentation of malignant hypertension, microangiopathic hemolytic anemia, and systemic vasoconstriction. The hand may be affected with Raynaud phenomenon and later with severe finger deformities, often as claw hand deformity, where pip joint contractures are compensated with hyperextension of the MCP joints. Contracture of the first web space limits abduction of the thumb and thus inhibits grasping of larger objects. Ulcers may occur at the tip of the fingers due to poor vascularization. Often, these ulcers are very painful and have limited healing capacity. Further, thinning and possibly rupturing of the skin above MCP or PIP due to joint contractures may occur and lead to tendon or joint exposure, which increases the risk of infection. Digital pulp atrophy may also be detected. Autoamputation of distal parts of digits may occur. Complications include end-stage kidney disease. Differential diagnoses include dermatologic conditions such as amyloidosis, eosinophilic fasciitis, porphyria cutanea tarda, reflex sympathetic dystrophy, and nephrogenic systemic fibrosis, and systemic conditions such as idiopathic pulmonary fibrosis, primary pulmonary hypertension, primary biliary cirrhosis, cardiomyopathies, gastrointestinal dysmotility problems, and systemic lupus erythematosus. The diagnosis can be made based on the ECR or EULAR scleroderma classification criteria mentioned in this table. Please pause the video to take a closer look. Laboratory values that may be helpful in the diagnosis include ANA, which is positive in most patients, and specific markers of systemic sclerosis, such as RNA polymerase III, anti-topoisomerase I, and anti-centromere antibodies. An ECG, imaging of the joints, lung, and echocardiography, bronchoscopy with biopsy, upper endoscopy, barium swallow, cardiac catheterization, biopsy of tissue suspected to be affected, and nail fold capillaroscopy may aid in the diagnosis. The treatment of systemic sclerosis depends on manifestations of the condition. Scleroderma renal crisis may be treated with ACE inhibitors, which increase the survival from less than 10% 1-year survival to more than 70% 3-year survival, and blood pressure control. Raynaud phenomenon may be treated by keeping hands warm to prevent vasoconstriction, avoiding smoking and vasoconstricting drugs, calcium channel blockers, peripheral alpha-1 adrenergic blockers, angiotensin II receptor blockers, topical nitrate, phosphodiesterase inhibitors, stellate ganglion blockades, and digital sympathectomy. Skin fibrosis may be treated with immunomodulatory drugs such as methotrexate. Arthralgia may be treated using nonsteroidal anti-inflammatory drugs or low-dose corticosteroids such as prednisone. Myositis may be treated using methotrexate or azathioprine, and esophageal reflux may be treated using H2 receptor blockers or proton pump inhibitors. Interstitial lung disease may be treated with mycophenolate mofetil, and pulmonary hypertension may be treated using oxygen, diuretics, prostacyclins, endothelin-1 receptor inhibitors, and phosphodiesterase 5 inhibitors. More systemically, the goal is to fight the inflammatory process. Pharmaceutic agents that can be used include glucocorticoids, methotrexate, and tumor necrosis factor inhibitors. Surgical removal of subcutaneous calcinosis may be used, but surgical joint deformity correction is rarely indicated. Prognosis. Systemic sclerosis is associated with significant morbidity and mortality. The leading causes of death include pulmonary fibrosis, pulmonary hypertension, renal involvement, severe gastrointestinal involvement, and cardiac disease. The prognosis tends to be poorer for patients with the following characteristics: male gender, African American ethnicity, older age at onset, low BMI, extensive skin thickening with truncal involvement, significant or progressive visceral organ involvement, autoantibodies to topoisomerase I, or absence of anti-centromere antibodies. This video was part of our Rheumatology series, and it was on systemic sclerosis.